So I just want to say welcome to our community conversation on healthcare. And we're happy to have the opportunity to come together to tell you about some things that are happening both in the province and in this community. My name is Nancy McConnell-Maxner. I work for Nova Scotia Health, and I'll be moderating our conversation tonight. I do want to mention that this portion of the event will be videotaped and posted on the same site where you registered, so that if you want to rewatch it later, you can, or if there are people that were not able to attend, they can watch. In terms of the process, we'll kind of get into the logistics of it after. There will be commentary from our leadership team, and then we'll move into a question and answer period. So what I would like to do right now is invite our MLA, Tom Taggart, the MLA for Colchester North, to do an official welcome.
Thanks, Nancy, and so welcome everyone. Thank you all for coming out tonight, and I'll keep this brief. So I would like to begin by acknowledging that we are in Mi'kma'ki, the traditional territory of the Mi'kmaq people. I also acknowledge that people of African descent have helped shape the history and culture of Nova Scotia for more than 400 years. So I'm pleased to be here to be part of this evening's conversation with all of you and some of our health leaders. These are important discussions to have. I'm pleased to welcome my good friend and colleague, Health Minister Michelle Thompson, and Nova Scotia Health Interim CEO is not here. And they will provide an update on the work underway to improve the health system and answer your questions. And Health and Wellness Deputy Minister Jeannine Lagassé is also here with us this evening to help address any of your questions. Thank you all very much for coming, and with that I'll ask Minister Thompson to say a few words.
Thanks. Good evening, everyone. So my name is Michelle Thompson. I'm the MLA for Antigonish. This is my first kick at politics, and was appointed health minister shortly after we formed government. My background is healthcare. I'm a registered nurse. I've been a registered nurse about 30 years, push a little bit more than 30 years. I'm a graduate of St. Martha's School of Nursing and moved there from Cape Breton when I was 18 and graduated when I was 20, so you can do the math. Anyway, it really is a privilege for me to be the Minister of Health. First of all, to represent Antigonish, but certainly to be the Minister of Health, and I feel it acutely. Not only to meet the needs of Nova Scotians who are seeking care, but I certainly feel the responsibility and the hope that my former colleagues have to have someone with a healthcare background in this position. So I don't take it lightly, that's for sure. So are there healthcare workers or former healthcare workers in the room? If you could raise your hand. Yep, that's about how it works. We usually have about 30 to 50% of healthcare workers in the room, which is really great because we can have a really open and honest dialogue. So this is really not about so much us telling you. We will tell you a little bit about what's going on, but we really do want to hear and answer your questions and tell you a little bit about what we've been up to. So we were elected on a promise to fix healthcare, and we knew that it was going to be a significant a big hill to climb. Healthcare has been de-invested. Like, we've been losing money out of healthcare for a really long time, and that is infrastructure, it's our buildings, and also in our people, right? So this constant looking for efficiency, healthcare costs money, and this constant push towards looking for efficiencies at a time when our population is getting older, not just here, but around the world, our boomers are getting older, and people have more opportunity to get treatment and medications that help us live longer with really complex illness. So things that we live with and live well with now would have been things that our grandparents would not have survived. And so now we have longevity, there's more people who are aging, and we have a healthcare system that's under pretty significant strain. So the past is definitely not the future. The way we got healthcare as young people is not going to be the same moving forward. We have to do things differently. We need to do a lot of different things, and we're going to talk to you a bit about that. One of the first things we did was change the leadership structure. So Nova Scotia Health and Department of Health and Wellness were two parallel entities, and they continue to be two separate entities, but for the first time in the history of our province, now the leadership from Department of Health, Nova Scotia Health, We have an administrator in Janet Davidson, who's a retired registered nurse. Well, retired, she's still working. I don't know if nurses ever retire. And then we have Dr. Kevin Orrell. And this group sits together on a weekly basis and speaks on a daily basis about how we make decisions as a system. And that's been very, very helpful. It's allowed us to go more quickly, make decisions faster, and try and make some change. So, tonight really is about having a chance to tell you what we're doing, and I'm going to ask Bethany McCormick, who's here. She's the VP for your zone, and Dr. Aaron Smith to come and talk about some of the things that are happening in the zone, locally, et cetera, so that you know. And then we'll get to your questions. Like, that's really here, but we want to give you some information before we answer your questions. So I'm looking forward to tonight. I'm really grateful that you came out to spend time with us, and so I'll turn it over to Bethany.
Thank you, Minister, and good evening, everyone. So as the Minister has said, my name is Bethany McCormick. I'm the Vice President of Operations in the Northern Zone, including this area, and I co-lead with Dr. Aaron Smith, who's here with me this evening. My background in healthcare is as an occupational therapist, but I've been in healthcare leadership for over 20 years, and in the Northern Zone in this role for about 2 years. So to start off this evening, I just wanted to mention a few highlights from this community and in the Northern Zone around some of the things we've achieved, but also acknowledge some of the areas that we continue to work to improve. So here in Lillian Fraser Memorial Hospital, we've had the official opening of the new Urgent Treatment Center on January 16th. This new service has been really well received to date since opening. The teams have been very excited with delivering the service, and the patient feedback has been very positive. This service allows access to non-life-threatening but urgent health care and provides consistent coverage and days of service in the community, which is really valuable. We had previously quite a high rate of closure, as you would all know. Appointments can be made by phone, and you can also walk in. So far, since we've opened, we've been doing a regular review of processes and how the days are going, making adjustments along the way. But overall, it's been receiving very positive comments from staff, physicians, and patients and families. We've had an increase in the lab appointments available in the site by changing some of our booking processes and really optimizing all of the process within that area. So blood collection and lab is more available, and we're still working to increase that. We've also had an increase in our physiotherapy service, and we're also working to link physiotherapy up with the urgent treatment center service. So if you're coming in for a muscle issue or something that the doctor thinks would be valuable to see a physio in a very timely manner, we're trying to connect those two services together and really expedite those appointments, and seeing some good results from that already. We've had a roof reshingling project in the hospital and a sprinkler upgrade last fall. We've also had the renovation to the primary healthcare area, where we have now new, improved, and larger clinical spaces. And we have added some new positions in the site. So we now have an assistant manager position, and this is dedicated to the Tatamagouche Hospital. And the site manager is now dedicated to Lillian Fraser and Sutherland Harris down the road, and that's a shared role. We've also introduced new positions to support the inpatient team, so care team assistants and support aides, and these teams work together to really support the nursing providers as well as the patients and families with the care they need. We also have a very active and positive relationship with the Foundation and Auxiliary, and a recent commitment from the Foundation to purchase new diagnostic imaging equipment, which we're so thankful for. Our biggest area of focus in the organization continues to be on our people, retention, recruitment, training, and we do continue to work hard on stabilizing and increasing the recruitment at the site. I'm going to pass it over to Dr. Smith now to speak a bit about primary health care.
Hi, everybody. My name is Aaron Smith. I'm the Medical Executive Director for Northern Zone. My background is in family medicine. I was a general practitioner just down the road in Westville for the first part of my career, and I've been in this position for about the last 2 years. Just to tell you a bit about primary care in the local area and in the surrounding area. really happy to say that we've stabilized the primary care team here. We've grown it. We now have 5 physicians, 1 NP, 1 RN, and 1 LPN, and administrative team working together to service this community. The other really great thing that's happened is that team got together and really provided us with the idea around what the urgent treatment center could and should be in the area. And we followed their lead, we supported them, and it's been implemented as of, Barbie, what date was it? The 16th of last month, so it's brand new. Our feedback we're getting from providers and patients has been wonderful. So it makes me really hopeful for how that service will continue to provide care for this community. The Tatamagouche area has one of the lowest rates in the zone for unattached patients. So the team here has done a really good job at getting patients onto the rosters into the primary care team here. We anticipate that all folks in the area who need a primary care provider will be offered a spot within this collaborative clinic, I think by this coming summer, which is great news. Those folks will be added onto the list through the Need a Family Practice Registry. So if anybody in the room or anybody in the community you know of doesn't have a primary care provider, please ask them or yourselves get your name on the Need a Family Practice list right away. For those of you who aren't attached to a provider but still need care, we obviously have the Urgent Treatment Center. I pointed that way. I think it's that way, up there. That way. Thank you. Just realized I pointed randomly, but that way. We have the Urgent Treatment Center. We have the Urgent Treatment Center just that way. But we also, all folks who don't have a primary care provider can access care through Virtual Care Nova Scotia, and also can be accommodated at our primary care clinics around the zone if they need in-person care. We have, hopefully, one of our big successes was we had a family medicine resident come and train in the area and be welcomed in the community, and has now joined the primary care team here. We hope to be able to place another family medicine resident within this team, I hope this summer. So if you see a new young doctor around your town, please take a moment and say hi and welcome her or him, and we hope they have a similarly wonderful experience. Some other great news is the Diabetes Education Center and the primary health care team will be offering a monthly satellite clinic to the local area starting this month, which is really great news. If we kind of go out to the surrounding area in Colchester and Cumberland counties, we continue to recruit more family physicians and NPs to attempt to stabilize and strengthen access to primary health care. We're introducing more team members at the network level, including other allied health folks such as pharmacists and social workers. And one of the other really great programs that we started is the Unattached Newborn Program. It was established last year for little babies that don't have primary care providers. So that program attaches them to primary care providers, and thus far we've been able to attach 250 newborn babies to primary health care providers going forward. We continue to implement and expand practice supports programs around the zone, which helps collaborative family practices optimize their approach to access and how they use technology and how they book patients. And this will be available to all primary health care groups in the very near future. In the Truro area, we've recruited 3 new family physicians to the Truro Collaborative Practice since January of 2022. They're all taking patients from the Need a Family Practice Registry. The Truro Collaborative Practice has added exam rooms to accommodate another newly added physician and further increase their service capacity. The Truro Primary Care Clinic, which is designed to provide in-person care for folks that don't have a primary care provider, is participating in what's called a Sprint initiative, and it's going to help them streamline their processes and enhance and improve access to that clinic. And at that clinic, they've had around 800 in-person referrals to support care continuity for the unattached patients from the Virtual Care Nova Scotia program. We've had and been working on ongoing well-established partnerships with First Nations health centers in both Millbrook and Sepenekity, and also in Pictou Landing First Nation. And we've also established partnerships with the Truro Primary Care Clinic and the local physician advocate for sexual health to operate in the Truro Sexual Health Clinic. In terms of risks, we certainly know of lots of folks that don't have the access that we would like them to have for primary care. It matters, and we're working very hard at recruitment and to try to stabilize teams. As I said, we're very fortunate in this community that we have such a wonderful primary care team, and we hope to accommodate all folks in the local area onto their rosters. And we're working hard to achieve similar great results right across the zone. So thank you all so much for your support of the team here. And as I said, if you see a new resident around, please try to welcome them, and hopefully they'll like it. So thanks very much.
Thanks, Aaron. I'm also going to speak a little bit about the mental health and addiction services available in the area and in the Northern Zone. And in addition to having the privilege to lead in the Northern Zone, I also work with the Mental Health and Addictions Program provincially. So I wanted to highlight that we've had 3 new psychiatrists join the Northern Zone in 2022-23. And one has started, and 2 more are starting very soon, one in the Colchester area and one in Pictou County. Northern Zone has also launched a national advertising campaign that's really focused on recruitment of clinical therapists, so the folks that provide treatment, counseling, group therapy, and one-to-one therapy. And it showcases the local areas within Northern Zone really to promote that sense of community and attract professionals to the area. We've also had the opportunity to add registered nurses into our outpatient teams. This is to optimize the ability of the psychiatrists to do the work that they can do, but also support follow-up medication reconciliation as well as early psychosis programs. We've also had a really great opportunity with our local policing services to engage with them on crisis intervention training, which allows us to partner with them in a different way with clients that might cross between the policing system and the health system. We share information more readily once this training has happened, and it really is supportive to the patients and families that might be experiencing mental health and addictions concerns. In the zone overall, we have our psychiatry inpatient beds in Truro, and we've been able to increase from 13 beds available to 18 beds over the last year, so that's a net growth of 5 beds. And we also have nursing staff who are really focused on elder care with mental health and addictions, working across the zone to support our aging populations that have mental health care needs. We also are piloting a brief intensive outreach service to work with children and youth who have autism at a younger age and support them in the school. We have a new recovery support center, which provides addiction medicine care in the Truro area, and it's co-located with the opioid recovery program. And these renovations will be starting this summer so that the new space can also support outpatient withdrawal management services in the same area. So the programs will be co-located. It provides a lot of opportunity for support to the patient in the one area, and groups will also be launching in Truro in the coming months to support this need. We recognize that mental health and addictions continues to have work to do to shorten our wait times for outpatient services, as well as in the area of recruitment and retention. We continue to have a number of psychiatry positions that are vacant, and we're working with all of our teams to recruit for those. And we also do have a number of efficiency initiatives and process improvement initiatives underway on how we utilize the available hours and resources in the outpatient service to get the most out of the available team that we have to really improve on wait times. So we continue to focus on better access, smoother access, and navigation in the system. Pass it back to Aaron to talk a little bit about public health.
Thanks. So COVID is still with us, of course, but I'm happy to say our response to COVID has really stabilized, which has allowed our public health team, who have been stepping in and helping us respond to COVID and keeping us all healthy and safe. They are now able to be back into the roles, which has allowed us to restart many of the important public health programs we have going. So some examples of that are the Early Years program, which provides universal screening for newborns, both in community and in hospital. The Healthy Communities team has restarted work in health promoting schools, such as youth engagement, school healthy eating programs, and youth health centers. Also, really focusing on increased access to vaccinations. In response to hearing citizens experiencing issues booking flu vaccines at pharmacies, at the health clinic, the healthcare conversation in Truro, we've added flu vaccines as an option at the COVID mobile outreach clinics. Public health continues to offer vaccines to clients who are not able to access a primary healthcare provider, and these immunizations will be available either in office or through a mobile outreach immunization clinic.
Okay, so thank you for that. And I do feel like I need to say that the reason we were taking our masks off is we discovered early on in the process that when we speak with the masks on, it's really hard to hear. So we do take them off. And so now we're going to get into the question and answer portion. I'm going to stand up. And so essentially what we have found works fairly well is that we will take questions from the group that's here. We have mic runners. I'm not sure, we didn't actually talk. Okay, we've got mic runners at the back. So if you have a question, you can put your hand up and someone will come to you so you don't have to get up and move. They'll bring you a mic. There's a couple of kind of ground rules we kind of figured out too. So if someone's asked a question already, we'd ask you to maybe not ask the same question again. It just gives us an opportunity to get more breadth of answers, and it makes just gives us more opportunity to talk about more things and to get more answers. So that's the one thing. The other thing is we try to do one question at a time, and so that way we can get to as many people as possible. And the third thing is the commitment that if we run out of time, and sometimes, frequently actually that happens, that we get toward the end of the evening and there are still outstanding questions and we can't get to everyone, that the cards that you got when you came in, you can write your question on that with your contact information, either an email or a phone number, and someone will get back in touch with you. So I don't want anyone to leave feeling like they didn't have an opportunity, well, they might leave feeling they didn't have their opportunity to get their question asked, but you will have an opportunity to hear back. Does that make sense to everybody? Is that okay? I get the nods in the beginning because at the end sometimes it's hard when you're the person with your hand up. So what I think I'll do is actually, we have some submitted questions too. And if you have questions that you don't want to ask, like you've got something burning but you don't really want to take the mic and ask it, you can give the mic runners the card and I'll ask the question for you. So just so you know. So I am going to start with one of the submitted questions just because it gets things going sometimes and gets the thought process if you don't have one already in your mind. So the first question is around virtual care. It's kind of a long question, so I might just summarize parts of it and ask the panel to respond. So the question is virtual care going to be a method to give healthcare providers more time for patients in office care? If patient-required prescriptions, will they be covered by Blue Cross Seniors Plan? Will the Health Canada Act be enforced to provide coverage according to universal healthcare policies? There's a lot of questions in the question, but are the walk-in clinics going to be covered by our present system in place? And in regard to ambulances being called and having to go to larger hospitals, will those fees be covered by the plan? As a senior on fixed income, there are grave concerns about what changes will affect us. Can this be explained to ensure confidence in the system is being implemented? And thank you.
Okay, we might be here all night. So we'll start. Okay, so the first one is around virtual care. Is it going to give health providers more time for patients in office care? So I'll start and I'll tell you a little thing. So currently, virtual care is offered to anyone who is on the Need of Family Practice Registry free of charge, right? So it's an opportunity for them to access care. So if you're on the Need of Family Practice Registry, you should definitely make sure that you're signed up for virtual care. If you need virtual care, you would go on in the morning, you make an appointment. But if the primary care provider that you see on virtual care feels that you need to be seen in person, The primary care clinic that Dr. Smith spoke about, they will refer you so that you can actually have an inpatient visit. So even though there is virtual care option, and some things can be done very easily over virtual care, but sometimes you do really need to be seen by a practitioner. So they can refer you to this primary care clinic, and you would be able to see someone in person for whatever it is that you require. So currently, it's only available for free, publicly funded to people who need a family provider. People who have a family provider, I know, so we talk about attachment, which is the people on the list. I need a family practice registry. I don't have a primary care provider. I don't have a health home for my healthcare needs, is not the same as access. So there are people who have a primary care provider and for whatever reason have to wait extended period of time in order to see their physician or their nurse practitioner. And we know that that's an issue. So I'll just give you an example. We have developed what we call a practice optimization team who will work for free with primary care providers to support them in having I don't want to say more efficient, because I know there's a lot of work, but to look at the processes in the office to see if there's a way that can be changed around. So Dal Family Medicine was a pilot project. That clinic was feeling very overwhelmed with the roster of patients that they had. They felt that they were going to have to actually ask some patients to move along because they just felt they couldn't handle the volume. So that practice optimization team, which consists of industrial engineers as well as people who are very good at administrative processes, that is not me, I would be no help in that clinic, went in and they looked and worked with those clinicians for 4 days. And at the end of the 4 days, they made recommendations, and based on those recommendations, that practice was able to actually take over 3,000 people off the Need a Family Practice Registry. Because they looked at the processes, they looked at who was working and what they needed in that clinic in order to make it more efficient. And so that team now is available to practices because we do want people to be able to access their primary care providers. So those would be some of the things related to office care. So some of our physicians are doing virtual care, and some of our nurse practitioners doing virtual care, but they all, they are also doing in-person, face-to-face care as well. If the patient requires prescriptions, are they covered by Blue Cross Seniors Plan? So I don't know if you, Natalie, if you want to talk a little bit about seniors pharmacare, or if you, or Natalie's here. She's the boss of it, and it's the easiest way to say it, and she can explain it better than I can. So.
Absolutely, thank you. So I think the reference is probably to the Seniors Pharmacare program, which is administered by Medavie Blue Cross on our behalf. So it's tough for us to say what's going to be prescribed at any particular point in time, depending on the patient, the prescriber, and what that discussion is. That's usually where that's made. But what we do have is the formulary, which is a list of products that are covered on Seniors Pharmacare, is available online. So it talks about which drugs are covered, which drugs are not covered, and whether there's any conditions for that coverage. So what we always tell people to do is when you're in and talking to your primary care practitioner about if you're needing a prescription, just let them know that you're on the Seniors Pharmacare program, or really any of our programs, including Family Pharmacare and some of the others. And then they do have access to that information so that they can help make a decision and choose something that would be covered under Seniors Pharmacare. Oh, ambulance fees as well. Ambulance fees, we don't provide coverage for ambulance fees. There is a charge for ambulance fees, but we do have 2 programs in place. So there is I blanked on the name of it. It's a program for financial appeals. If affording the ambulance fee is going to be a challenge for you because of your income, then there is a process that you can apply to have that fee waived or perhaps reduced. And then we also do have another program that does allow you to pay that fee over time as well. So if folks do want to get some more information about that, we can give you the contact numbers, but those measures are in place to help people who may have some challenges affording those fees. Yeah, so if you're being transferred from hospital to hospital, I think that's important. You may be, admitted here and then have to be transferred to, a larger hospital in a center. That's considered a transfer versus an ambulance ride. So the charge for the ambulance is when you're calling from your home and being transferred to the hospital. Okay.
I think that's it. I think that's the list.
Okay.
Thank you. Okay, I forgot to say that I also tend to point when we do this. So I point. Well, what I'll do is, if you put your hand up, I'll point at you, and I know it's always that rudeness to point. But look, first hand up. I'm gonna point to you. Oh, 1 and 2. So if one here, and then here. So we'll go. Oh, do you want me to read it? You're gonna read it. Oh, it's me. Okay.
I guess, first of all the negativity around healthcare, I want to at least acknowledge all the hard work that you've done, and these initiatives sound really great. And I guess we hear more about the negative than any of the positive, and so I really appreciate that. The one thing I've heard over and over, though, is, of course, our aging population, and also the move to more technology to replace some of those human pieces that were being done. And my concern as an aging population, the challenges for some to use that technology, either to have the internet ability, number one, and the cost of that. So when they're making these decisions of being much more technology driven, then I think we need to look at universal internet, because if you can't see your doctor without an internet or to make the appointment or those things, we're still going to be in that backward stage that we are. So those great initiatives are wonderful if we don't have the roadway in place for them to be actually as effective as they can be. And that's for those who want to or have the ability to pursue the technology piece. I have my mother here. I'll say that she does it. So those, like healthcare, I've always said that in healthcare, if you are fortunate enough to have family or loved ones, then you're going to make it. But all those people that fall through the crack because they don't, or don't have the ability to use internet, those are the ones I'm really concerned for.
So certainly we've heard that comment before, and it's one that we are very concerned about, and we're thinking about options to help folks that don't have ready access to internet or good technical literacy, digital literacy, to have options. So one is an example that we had with another community where we entered into a partnership with another health foundation in the New Glasgow area, actually. We partnered with the local library, the foundation, and our virtual care team to train some of the library staff on how to help people in the community onboard onto the virtual program. And they actually set up a private room in the library where people could come in and actually get help logging on, signing on. And if you needed help on the day of your appointment, they'd also help you get on, and then they'd leave you privately to have your visit in the library space on a virtual network. So that's an example of some of the things that we're doing to try and close that gap. But we do know that we also need to be mindful of some of the populations that either don't have, even the means to get to the library, for example, or they can't have internet or phone service or a smart device. And when we're creating these avenues, we're continuing to think of other low-tech options that can support, like continuing to have things like 811 available and other services that can be accessed through, lower tech items. And then the great thing in your community now is if you have a urgent but not life-threatening issue, you can also seek care locally at the Urgent Treatment Center.
And I think that this evening, if I'm correct, some folks from Virtual Care Nova Scotia are here at the back of the room. So if there's anyone who is on the Need a Family Practice Registry and would like some help signing up with Virtual Care Nova Scotia, we do have some staff members here tonight who would be able to help you with that right here.
And if there's a seniors group here and you have some ideas about what would work specifically for your community, we're happy to hear about that so that we can support, because what works in one place may not work in the other. And the other thing that I'll just mention is I'm not sure about the coverage for internet, but there is a program through our government, where if you don't have internet, and I'm sorry, I'm not very techie, but you can buy the Starlink. We will give you a $1,000 grant or whatever it is to buy the box. You pay for the subscription, but we actually help you invest in the infrastructure so that you can have Starlink internet. And apparently, it's very effective. So if there is somebody who can't physically get internet because the wire or whatever, however it hooks up. I don't know, like however that works. If you don't have the wire, then we can give you the beam. I guess that's how it works. So that's what I would say. We can help. Tom Taggart, I'll give you his office number.
Way across through 311 and that have had some real challenges with being accepted to that program. So if that's happening to you, call my office and we'll try and work it through with you. It is a challenge. Part of the challenge is that Cumberland and Colchester signed a deal with Explorenet 3 or 4 years ago, and they were supposed to have internet here by now. And so what happens is they say, when you call into the StarNet folks, they say, well, you're going to be serviced by Explorenet. And when, in fact, I don't know when Explorenet's going to get here, maybe 2030 or something like that. I don't know. It seems like what's going on. So just saying, so give us a shout, and we may be able to help some there. Thanks.
Didn't know if you wanted to say something. You just hold the mic. Okay. So I have a submitted card that I'm going to read. It's about wondering what happened to EHS and paramedics about emergency being open in the evening, and looking for a comment on that. What was that? About the EHS and paramedics, wondering about the emergency department being open. I think the urgent.
So I can start, and Aaron, feel free to jump in as well. So when we began planning for the service changes here in Tatamagouche, one of the things that we do is engage with our local healthcare team, so the physicians and providers in the hospital, to review how the service has been going, the types of patients and healthcare needs that have come into the service over a vast number of years, to look at the services that are needed, and then work with the team to really build a service that will match to the majority of the patient needs. And so when we designed the service with our healthcare providers, the design was for a 10-hour daytime service, 5 days 1 week, 6 days the next. And that service does provide non-threatening but urgent care needs. And if someone comes to the site and their care needs are more urgent than what the site can manage, we have a relationship with our EHS colleagues where we work with that patient to call 911, and the ambulance will come to the hospital as if they were coming to your home. So they will actually come and pick you up and take you to the larger site, the other areas that are able to provide more acute health service. Did you want to add on to that, Dr. Smith?
Yeah, this is a concern that's brought up quite a bit across communities, of course. And I want to start by saying that the team here and the providers here do an amazing job, and they always have. If you are critically ill, so if you're having a stroke or you're having a heart attack, despite how great the team is here, the best place for you to be is in the back of an ambulance, lights and sirens, going to a regional center. When you're in an ambulance, you're not just being transported, you're getting amazing care provided by paramedics and advanced care paramedics, but they have the ability to consult in real time with an emergency physician in the control center who can direct care, can provide advice, and paramedics can also provide interventions. So for example, they can give types of blood thinners and clot busters on the way to the hospital. So it's hard, I think, for communities, and I get this, to say we don't have the emergency room at night, but from a clinical perspective, if you're very sick, the place for you is not a community emergency department, it is in the back of an ambulance, lights and sirens, going to one of our regional centers, where you will get access to the care you need on the road, plus also at the larger emergency center and potentially intensive care unit. So, thank you.
Okay, thank you. Are there any other? Oh, okay. I was thinking, put your hand up quick, because then sometimes everybody does it all at once, so it's good to stagger. It's good.
I'll get it in early. Again, I just want to thank everybody for being here this evening, and I've been part of a couple of these meetings, and I commend you on what we're trying to do for the urgent care. My concern is what happens when we need an ambulance. And this plan only works if we have 24/7 ambulance coverage. And we get as somebody said earlier, a lot of negative press about ambulances sitting in hospitals, and we drive by the ambulance shed up there and it's empty and we don't see anybody around. So I think in order for the community to be comfortable, we have to be reassured that ambulance coverage is that emergency coverage, as you said, the mobile emergency room at one of the other meetings. And I've seen it work, and it does work as a firefighter. And I think we just need to be assured that if, in case we do need emergency care, and hope we don't, that it's there. And it's only there if the ambulances are in the community, and that's what's scary.
Okay. So thank you. If you've been at other sessions, and we've been at, I think this is our 20th one, we've heard and answered questions about this at almost every session. I think that what we're trying to do, and what we have done, and some of our partners are here from EMCI, who provide the ambulance service for the province, and also a representative of the Paramedics Union is here with us tonight as well. And so what we've tried to do, though, is institute initiatives so that ambulances are there for the emergency care. Our system was set up at a time when we were using ambulances to transfer patients between facilities, from one facility to another for a test, and we were using 2 paramedics and sometimes an ambulance for that, not a patient transfer unit. So what we've started to institute is a new category of worker, a transport operator. And so there is someone who is not a paramedic now who drives the patient transfer unit. And what we've been able to do by doing that is dramatically reduce the amount of, we've increased the number of transfers that are being done in that manner. I can't remember how many per month, Jeff, that we've moved to. We've gone from about 85% of transfers being done by 2 paramedics in an ambulance down to about 22%. And our goal is to get to 5%. So by instituting things like that, that's helping us to keep the trucks on the road for when we do need the lights and sirens, as Dr. Smith has said. So we've also really increased, and you may have heard just in the last couple of weeks, that we also know that we need more paramedics, that's one of the things. We have just as with all our healthcare workers, we have a large shortage of paramedics, and we need more. So we just announced 2 weeks ago about that we're going to be instituting right now. The program for paramedic training is in Halifax and Sydney, and we're expanding it also to Yarmouth and Pictou County, and there will be additional seats there. And I can tell you in the first day after it being announced that we had 54 applications in Yarmouth alone. So it is people are very interested in joining the program. As part of that also, there's a tuition relief program associated with it. So I'll let Jeff is our executive director, EHS, in the department, and he can talk about a few of the other things that we're doing. But it's really all about trying to make sure that the ambulances and the paramedics are being used to their highest and best use.
Not a lot more to add. The deputy really nailed it, but it's all about creating capacity. That's really where we're at. You would have probably heard about our non-critical care flight plan as well. And I'm sure you're looking at that thinking, well, it's Sydney and Yarmouth, how's that going to help us here? That will inherently create a great deal of ground ambulance capacity, because when an ambulance leaves Cape Breton and we take a number of patients each day, they're gone for 12 hours. And when we put this airplane in, that's going to be more ambulances available in Cape Breton, more ambulances available in the rural area. What you have to remember is our system is one, and so it all kind of moves together. So that's about creating capacity. The relief, the tuition relief thing that the deputy talked about, to go to paramedic school, it's 54 straight, very intense months, costs about $19,500, and we're going to be sponsoring in excess of 150 seats over the next year, and the tuition relief looks around about $11,500. So the first week, as the deputy said, the first couple of days, we couldn't believe the uptake, and so this is again going to help us do these things. And the last thing I'll just pull on, that continuation of separation about the work that paramedics don't need to be on is absolutely key. And you did mention you're a firefighter, so I will thank you. Used to be, right? So is there any of our medical first responders? Yeah. So the system, there's no doubt, is going to change. We are already seeing that these things are starting to drive some relief. There is no doubt. There's incidents that you read, they scare people. We want you to know, if you're ill, you call. We will get to you. In our communications center, we've got a clinical paramedic specialist that works in there. We've added a nurse that works in there. So there are many calls that we get that we don't even need to send an ambulance. We just need to give somebody a care plan. And we have a physician, and those people work in a clinical trifecta in there. I don't know if you know this or not, but about almost four out of every 10 patients we see don't go to the hospital. We're able to give them a care plan, which again creates capacity. So we're doing many things, and we're already starting to see some of the results of that. 54 months. I think you meant 54 weeks. Thank you. We would have seen those numbers go down really quick.
If I may, I just wanted to maybe add on about some of the work that we're doing on the hospital side, so that when the ambulance does come to some of our larger centers in particular, that we're working really quickly to get the ambulances offloaded and patients moved into the emergency room and the trucks back on the road. So we know that the emergency department is the entry door for the hospital, but it's connected to the beds upstairs and also connected to our ability to discharge patients home. So it's the whole system that needs to move at once to keep the offload moving quickly and the emergency department flow being really efficient and patients moving upstairs. So some of the things that we're doing are looking at the sites in the province that have the best offload results. And I'm really happy to say that a hospital not too far from you, the Aberdeen, has the best offload results in the province. So when we looked at what makes that result the best, what we've seen is that the whole site, whether it's the inpatient unit, the medicine unit, pharmacy, housekeeping, emergency department, they all know that the movement and flow through that hospital is job one every day. And so they are really interconnected as a team around solving that patient moving to the best place, as their number one job for everybody. And so what that is allowing us to do is make sure that the person gets pulled from the stretcher, off the ambulance goes back to the road, they move into the emergency department. That team works really efficiently to provide the care there, and when they're ready to move to an inpatient bed for admission, we move them upstairs as quickly as we can. But to move them upstairs quickly, we also have to have people being discharged home or to their next destination as quickly as we can. So we work with our seniors in long-term care, home support, placement to long-term care to really have our care plans ready to go so the patient can move on to their next location. So it's all of those pieces in that whole pipeline, as I like to call it, or system, that need to move together. And when one part stops or gets stuck a little bit, things back up. And it often backs up in different places at different times. So the investment in long-term care beds, the continued investment in paramedics, the continued focus on flow processes in the hospital, teams working together will really begin to see everything move smoothly. And we know that flow of the patient and the patient's journey through the hospital is something that you have to have your eye on every minute of every day, 7 days a week. And we're also investing in technology that supports that, called the Care Coordination Center, that gives us real-time data to be able to see where there's a bed available in the hospital or the system that we can quickly move a patient up to. So right now, if you're in the emergency room and you want to know if you can move a patient upstairs, not such an issue in Tatamagouche because you have a little hospital, you know where the beds are. But if you're in the QE2 and you need to find a bed, it's calling the floors and saying, do you have a bed? Is it ready? Is it clean? Can I send the patient? Trying to find the bed through manual processes. Now we have technology on screens that shows there's 3 beds in this unit available. 1 will be ready in a half an hour. The patient can go up. So we're scaling that very soon across the province, and we'll be the first province in Canada that will have it province-wide. So we are really excited about that technology. We're excited about the processes we're putting in place. It takes time to create those changes, but everybody is really committed to understanding what makes a really great day when we offload well. And Jeff and I talk about this all the time about, what was great about today, what can we learn? And if we have a day where we're really, backing up, what's causing it and how do we fix that problem?
Okay, thank you. I have another submitted question that I'm going to just read and look out and see if we have, I'm trying to do my scan of the room, but I am going to read one of the submitted questions. So this question is about support staff for current medical staff. Is there a plan to increase lab hours in our facility? And if not, why not? Can it be made a priority for rural facilities that need to take the pressure off larger facilities? And that would include diagnostic imaging as well.
Yeah. So as I mentioned in my opening remarks, we have increase the number of blood collection appointments available across the Northern Zone, including here in Tatamagouche. And since we implemented this initiative to increase blood collection appointments, we've added 300 appointments a week across the entire zone in the last 4 to 6 weeks, I would say. And with the renovation that has just been completed in Truro, we'll be able to add an additional 30 to 50 appointments per day in Truro Hospital now for blood collection. So that's like 350 to 500 more appointments a week that we've created for blood collection. And we know getting in for a blood collection appointment can be really tough, especially if it's a fasting blood collection that you need. All those early morning appointments go really fast. So we've added capacity in the blood collection. And we've also invested in a full-time medical lab assistant for Lillian Fraser. And this person is able to work with the team in blood collection, but also carries out point-of-care testing and supports the medical staff on, doing some of the tests that need to be done. We're also increasing through a test and try our diagnostic imaging X-ray service. Previously hadn't been available always on the weekends, and we're introducing it one day on each weekend right now to support the physicians, because we know that's an important complement to the urgent treatment center. And we're continuing to look at ways to grow both of those services in the site.
Okay, thank you. So is there any other, okay. Do you see somebody too? You have to put your hand up high sometimes. Sometimes it's hard to see, so if I don't call you, but go ahead.
Yeah, good evening. I'm still really concerned about the ambulance and the ambulance's time. I live on the 311, so I'm lucky that way. I'm on the way to Truro. But the time for an ambulance to get me to a hospital will more than double now. And the other thing is it's Nutby Mountain. It's bad weather over Nutby Mountain. The 311 is not a great road. And the only time that I ever saw my dad close to tears with his health care was when he was going to be put in an ambulance on a gurney and go from here to Truro, and how rough that road was. He was in pain, and he just didn't want to have that ride. So I ended up actually driving him in my car to Truro. So, it isn't just that the paramedics, will do their utmost to help you. It is the timeline of where you are. You also get into the family members, and because we have older family members, that means that, there may be a wife or a spouse that's in their 80s following that ambulance, and instead of coming to Tatamagouche, they're going all the way to Truro or New Glasgow or Amherst to follow their loved ones. So those are the concerns about not having Tatamagouche accept ambulances. Thank you.
I can speak to that. And I've been there. I've been there recently with a family member waiting for an ambulance and then following it in. And I know what that feels like. And I will say, I acknowledge all of your concerns. And I know I do know how hard it is, actually. But I think we also have to bring it back to outcomes and safety. And really, as I said, you may be able to get here quicker. And again, I'll preface this by saying the team here is fantastic. You may be able to get here quicker, but are you receiving the care you need here? And for urgent situations, my answer is you are not. And that's not against the team, but you are not getting the care you need here. If you are emergently, so this is above urgent, if you are in an emergency, you need to go to a larger center, and the safest place for you to be on the way there is in an ambulance. So I hear and acknowledge everything you're saying, but if we focus on outcomes, this is not where you want to come.
Dr. Smith, could we maybe talk as well about virtual hallway? Are you familiar enough with that around consultations as another example?
Yeah, absolutely. So I can talk to that. So there's also the options, a couple of virtual options that providers here can use, and it's related to your question. Two things that are happening in our emergency departments, which are one in emergency departments, one in kind of the more general medical system. In the emergency department in Truro, they're under the leadership of the team there and one of the physicians there, they've implemented a really innovative approach whereby lower acuity or less urgent patients who come into the emergency department are given the option to actually go into a virtual emergency department, which means you go into a room, you're accompanied by usually a nurse, and you connect with a physician, an emergency physician virtually. The feedback we're having from this from patients and from providers is fantastic. It shortens people's waiting time. They get the care they need. If there's any kind of exams they need to do, they have the technology to do that. So for example, if the physician needs to listen to your heart, the nurse can hold a stethoscope over their heart and the physician can listen to that at home, which is pretty cool when you think about it. So that's one great virtual initiative that we have, and that started right here in Northern Zone and Truro, and the rest of the province is saying, hey, we want to do that too. The other initiative that's really great is called Virtual Hallway. So Virtual Hallway means that providers, the classic way that, I'll speak to my example from being a family physician. So if I saw somebody, I did everything I could, but I knew they needed to see another physician. Maybe it's a cardiologist, maybe it's a psychiatrist, what have you. The way it used to work is I'd write a consultation, a letter, requesting the patient to be seen. I would put it into a fax machine. We would fax it off to the specialist. The specialist reads it, says, yep, I'll accept this patient, faxes it back to me, gets in contact with the patient. The patient then has to get in the car when the time is right, go wherever, we'll say Halifax, go for their consultation, come all the way back. And you think about like the time and the delays between when I say as a family physician, they need to see this other care, and there's all these little steps on the road. So with Virtual Hallway, what that means is that as a primary care provider, I can connect in real time with specialist physicians all across the province. So I could sit down in my office and have a conversation with a psychiatrist, for example. And they can provide me with the guidance around investigations, therapy, care, follow-up, which means that you can get the care you need right at your primary care provider without having to get in the car and go and go and go. Now that option is still available, of course, but it does give primary care providers the ability to provide more care, better care, closer to home.
Okay. Oh, okay. Thank you. I keep standing up.
Okay, so I'll go back to the EHS, and I'm a recently retired RN, old emerge nurse. So time is tissue when we're talking urgent emergency type. So strokes, MIs, things like that. So I know ACPs have a scope of practice. They do thrombolytics. So my question is, have we increased our number of ACPs within the province to help look after the rural areas with the closures of emergency departments? Because it's great if we increase the number of paramedics. And all the things that I've been hearing tonight are really great. We're making progress, right? I come from my practice has been 38 years, the majority in emerge, OR. I've kind of gone through a whole lot of different areas. So I've come from a tertiary care hospital to a rural area. And all my people said, why are you coming to a rural area where there's no care, right? I'm coming for peace and quiet. But I'm also aging. So I need to know that I have health care. And I have been in the position with a family member where I have waited, just here visiting, back before I retired. I waited over an hour for a relative that they saw my car in the yard. I was visiting my parents. Granny had had what they thought was a stroke. They pull in the yard, come running in. Shelley, come look. Yes, I come out. I assess. Yes, they are. Absolutely. I'm on 911. So I did the whole assessment. In the meantime, waiting for the ambulance, I sent the family member home to get the pills, find out the history, drug allergy, blah, blah, blah. I give the report and wait the hour. So in the hour waiting for EHS to get there, I've also gone over with the family, okay, you're going to Truro. This is what they're going to do as far as the CT. These are how strokes happen, and these are the things that you're going to be asked and the choices that you're going to have to make. And also, on the way to Truro, when Nan maybe doesn't breathe on her own, how aggressive do you want? Like, so I went in through the whole code status, everything. So when the paramedics got there, I just said, go. right? We're already an hour after. So just long-winded ACPs, are we increasing our numbers? Thanks. Thanks.
Charbel, would you maybe take that one for us?
Thank you.
It's like karaoke, you gotta get right to the front.
No problem. Yes. Hi, everyone. So my name is Charbel Daniel. I'm the Executive Director of Operations with EMC and partnered with the government and the EHS. So I'm pointing to Jeff, he's back there now, for regulation. So we are always focusing on recruitment and retention of experienced paramedics as well. And one of the programs that we have within EMC and EHS is funding for advanced care paramedics every year. So we know that the announcement just came out for primary care paramedics to help get the numbers up, but we also have funding for our experienced paramedics to go from primary care to advanced care. We fund about 25 of those paramedics every year to help keep those numbers up and to keep the experience and the knowledge within the system. So, all right, thanks.
I think it's really important to talk about the doc in the box. Like, so 24/7 now we have physicians who are in the comm center. There's, as Jeff said, and a registered nurse there as well. And so what that, that's such important practice support for paramedics in the field, and making sure that, sometimes I can do things as a nurse, but when I have a physician telling me that I can do this much more, I'm able to expand my skills. So that physician particularly is a very big support to our paramedics and allows them to extend and, be the hands and eyes and in the back of the ambulances. So that is now constantly. They always had communication support, but this person is there all the time. And it also allows, sometimes earlier people don't, this is a different situation, but sometimes people don't need to go to the hospital, and the doctor and the nurse also allow us to divert people who aren't critically ill away from the emergency room to the right care that they need. So that's been an incredible improvement, I would say, in terms of support for paramedics, but also making sure that there's, immediate support with that skill set in the room, even if they're not physically with them. So.
Thank you. I'm just looking around to see if there's other. Okay. We'll get you a mic. I know, whether you want one or not, you get a mic.
It all sounds wonderful. Sometimes I wonder that we don't put the cart before the horse, and the big food industry and big pharma are our enemy. However, that's another chapter for another day. Anyway, what are we going to spend on all of our new healthcare innovations for this year, for 2023? What will that figure be?
That's a secret.
It's my money.
I know it is. And if you have the stamina for 20 hours, you can watch Jeannine Lagassé and I answer questions on YouTube. So the budget is being formulated now. There are business cases that are brought forward. Like, I'm learning a ton about how this all works, right? So the business cases are being, developed, and and we'll go, so what happens is we go to budget estimates, and I never knew what that was till I was elected. And so what we do is we table the budget, and then each department, so there's 80 hours of questions available. So 80 hours between all the departments, and we report and answer questions to the opposition about how we're spending the money, and then we table the budget so that you can see it. So until it's approved, I can't tell you. And it's actually going through right now to say what we are approving and what maybe we aren't approving. So there will be more to say, but Jeannine and I generally have, we think we had 18 hours of questions to talk about each of the budget, and then we'll table it and you'll be able to see. So it's coming, is what I would say. But we are investing heavily in healthcare.
Minister, if I could just add to the question or ask in a different way, is out of our provincial dollar, how much of that goes to health?
About 41 cents.
Oh. So it's actually gone down in the last number of years, rather than, my understanding, it was very close to 50 cents out of that provincial dollar. So I'm just wondering what's considered encompassed in that number.
Yeah, you can probably answer that better,
Yeah, that some of the statistics are based on when the department had continuing care still within it. And now that there's the separate department of seniors and long-term care, and then there's also the separate office of addictions and mental health. So sometimes it gets pulled together, sometimes it gets pulled apart, but the department proper is about 41 right now.
You guys are really quiet. Like, there must be questions here. Oh, okay, Brenda's got another one. She heard quiet.
My question, and I think I submitted it, and I've had about 50 years of experience in the health system, the majority, not just in this province, but throughout Canada and internationally. And I'm asking a question not from a healthcare provider, but from a patient family perspective. And I commend you. And I, like every Nova Scotians, want you to succeed at this. My concern is about your consultation with patients, family, and public. It feels like, and as you described, great innovation that it's being done to us instead of including us to help you with the solutions. So I guess my question is, how much public patient-family consultation are you doing in order to come up with redesigning a system that we all want to count on?
Yep, that's a great question. So I'll start when we were first elected. So we spoke to thousands. First thing we did was actually speak to thousands of healthcare workers. So that was the first thing we did. The health leadership team, we started in Cape Breton and went all the way to Yarmouth. And we also had, so I would say at least like over 2,500 healthcare workers. And we spoke with them directly, the Premier and I and the health leadership team. In addition to that, we met with about 50 or 60 stakeholder groups, organizations, associations from across the province. All the different foundations, anybody that has a foundation or invested in healthcare. And so we had some ideas and looked at best practices around what would help. But when we talked to healthcare workers, they were really clear about the things, one, about their experience and what it felt like over the last number of years in healthcare, and ideas that would help. So out of that, we have a strategic plan called Action for Health, and it's built on the suggestions of healthcare workers and also best practices, leading practices around the world. And there's 6 strategies, and you can see what they are. And it's across the whole spectrum. So somebody mentioned it around, we need to start looking at health promotion and prevention. We need to look at how we can support our own health in communities. And I often say, I've said this at a few community sessions, I tell my colleagues in cabinet, I'm the minister of the healthcare system, and every single one of them is the minister of health. So education, economic development, all environment, everything. Each of those is a social determinant of health. And when they do well, we do well. Right through to palliative care and long-term care. So we have to look at the system as a whole. So after we did that plan, we also have a website that you can go on and see, one, how the system is performing the day before, so you can know how many surgeries are done, and there's information, but also how we're progressing with our goals. And it is taking, it's going to take some time. So now a year later, we've gone out, and this is our 19th community session. In addition to that, we receive a ton of communication, and we work very closely with our MLAs around solutions that would work, because what works in Halifax is not going to work here. Maybe there's some things that will work, but they're not always the same. So we have done a number of, I think, like I said, this is about our 20th. We come into community, we ask what's happening, we generally visit with the hospital. We have very close relationships with the zone directors, and the VPs, we expect them to work in community, in hospital, and I know that certainly Tom and Bethany speak on a regular basis about the challenges that we're experiencing, and then we need leading practices as well. So we do engage world-class people who, we went to Denmark as an example to see their healthcare system and see how it was applicable here. So we really are focused. We do get a lot of feedback. I think the health minister account gets about, it's like 2,500 emails a month. So we do get a lot of feedback. And in terms of the patient themselves, there is feedback through the system. So sometimes if it's outside of the acute care system, I get feedback directly, which is great. But in the hospitals, there is a feedback line and there is a feedback email where people are assigned to look at the quality of the care that you got. Sometimes it's to compliment the staff, but other times it's to work through when things didn't go well. And certainly, recently we experienced tragedies in our emergency room, and the interventions that we had been working on, some things we were able to accelerate, but certainly the feedback that we got from physicians and patients informed the interventions that we announced. So we work very hard to be on the ground and not in the ivory tower, is what I would say.
And so we recruit members of the community into our quality teams, and patient and family advisors have the opportunity to sit with us during our meetings where we review patient safety, access to care, appropriateness of care, planning and design of policy, and the patient and family advisors are a full member of that committee. They provide us feedback on, if we're designing a policy, they'll put their hand up and say, like, that's really not going to work for a patient. You might think that that's a good idea for you as providers, but did you think about this perspective? We've had patient and family advisors included in the design of the urgent treatment center here, but also in Parsbro, as an example, we had members that sat on those design committees with us to have their feedback provided to us. And we also in the organization have a group of patient and family advisors that we use as a patient and family advisory council. So this is a collection of patient and family representatives from various communities, walks of life, experiences with the health system and beyond, that we take problem statements to or ideas to, and we actually engage them in a consultation. We have a process where we refer something to them. They get the opportunity to ask us questions, give us feedback. One of the things that I can remember us doing is we were trying to design our public-facing data sites and our websites that give reports. And we're like, how does this work? Can you navigate this? Like, what do you think would be better? And they were just like, that is designed for the academics. You need to make it simpler. That's not going to work for me. And we took their feedback and we changed what we were doing. The other thing that's really meaningful, and I had the opportunity to do this just this week, I received a comment from a patient and family member that they wanted to tell me about their story. So that person provided me their number. I called them and I listened to their healthcare story. And there was some good in it, but there also was definitely some things we needed to learn. So with her permission, I've connected her to the frontline teams that provided her care for her to tell her story to those teams so that they can learn about how it felt to be the patient through that journey, and so that then we can learn to change perhaps how we interact with the patient or family, design a process differently, and maybe really exemplify something that we did well. So there's different ways that we do it. I think we need to do more of it. We do, as the minister said, review the compliments and complaints that come in, and if there's a trend that we see routinely, we try to implement a broader change. So we also have patient experience surveys that we do every year that gather feedback about what the care experience was. And one that we hear about a lot is that we don't help patients be ready for discharge with their medications from hospital very well. Like, that's one that we've consistently do poorly on across the board. So there's a whole quality improvement project underway with patients and families helping us design it to make that better, and we measure how we perform on that. So still lots more to do, but we do have different avenues where we try to hear the patient and family voice.
Thank you. Okay. Okay, thank you. I think if you're thinking about questions, because I find what happens is towards the end, that's when everybody's like, oh, wait, I have a question now. So if you're thinking of it, it's a good time.
I kind of have three, but I'll start with my one. So first, Minister Thompson, you mentioned when we were talking about the virtual care, and you said there's kind of two avenues, and I didn't quite capture what you said. But my question is, in order to qualify or participate in that program, you have to be on the list of need a physician. Has there been any consideration or any process for residents who are at home, may have a family physician, but they're housebound and cannot access their family physician? Is virtual care an option for them?
Yes, is the answer to that. We've been able to scale the service, province-wide for the Need a Family Practice Registry, but I think as part of the announcement that we made a couple of weeks ago related to improvements for emergency care, we did advise at that time that we are looking at being able to scale virtual care for people who are attached to a provider, but would like to just access episodic virtual care. Yes. So can't give you I don't have a timeline for you on it though, but it is very much on our planning.
I can add maybe just to touch that too, is that currently a lot of primary care providers are doing virtual care through their offices. So they have, many have the technology that's enabled that, whether that's by phone or whether that's by video conferencing. That's expanding every day. So I'm hopeful for a future where we all have access to that if it's appropriate. Yeah, exactly. Yep.
So, like I said, I normally stand up, but I can kind of see. So, are any other? Okay, yeah, you can keep going. I know my rule was one question per time, but you can go.
A couple of years ago, the department created an in-home blood collection program. I'm hearing there's a 4 to 6 week wait for folks to get blood work through that program. I'm wondering if someone can comment.
So when Nova Scotia Health does have in-home blood collection. It was created during our COVID response for certain individuals due to isolation or other limitations could not come in for care. It's not available in all areas of the province, for one, so there are limitations geographically. And it's also, there's a high demand and not always strict adherence to actually needing an in-home collection as the criteria. So we are working hard with physicians who are referring for in-home collection to make sure that the folks that need it, who are truly homebound, can't come in for whatever their reason is, are receiving in-home collections, and somebody who can come in is coming in. So I've had members of my team comment around, they called to book an in-home blood collection, and they said, well, can you come at 9? Because I got to get my hair cut at 11. And so that to me means, maybe I wonder if I should ask you if you can come in for an in-person appointment. And so we will explore that with the client. So it's also quite costly, and you can see a lower number of patients by doing in-home collection. So we want to reserve that service for the clients that truly need it and provide it to them. And so we're having to really kind of work on, I guess, the process of the referral and really honing in on those criteria.
So when the program first started, I had no idea what the wait time was. This is 4 to 6 weeks that I've just been hearing the last couple of weeks. Is that a new development? Have we always had to wait 4 to 6 weeks for that service?
So I don't have the comparator data on the wait time when we started versus now, and I'd be surprised if it was 4 to 6 weeks today, but I could follow that up. I don't have that information with me, but I do know that we've been struggling with demand, but we think honestly, I think the criteria has grown to be beyond what it was intended to be.
Okay, in front.
I'm going back a little bit, but there was a number that you could call if you did not have a doctor. What happens to those people who have been waiting years on that list? Is that going to the Virtual Care Nova Scotia or what?
So if you're on the Need a Family Practice Registry, you do have to sign up for virtual care, and if you don't have an email address, then you can call, I think it's 811, and they'll help you navigate and get you set up. The list, the Need a Family Practice Registry, is simply a list. It was never built with any amount of functionality. So that means that, if my name's on it and your name's on it, if all of us are on it, we don't have the opportunity to say that I don't have anything wrong. Somebody else may have chronic disease. Unfortunately, it was never built that way. So we are currently working now to make the list more functional so that people can go in and update their health status and all of those different things. The other thing is, there's no way to, if you get a family practice, you have to call and say, you can take me off the list. There's no automatic way to come off of the list. So the functionality of it is not great, but we over this period, we are working very hard to make it more functional and assist us. But the important part is that you do go to virtual care, because if you do have a chronic condition or something that you're very worried about, and you see someone virtually and they decide that you need primary care in person, they can refer you to an in-person clinic for you to get that care. So virtual care has been expanded, and it is a way to get, care until we can attach you permanently to a health home.
And I would just add, Minister, that if you access the virtual option, it doesn't remove you from the list waiting for the doctor or the nurse practitioner. You still remain on the list to be matched to a provider when they become available. It's a little bit like a temporary measure until you're matched to a clinic.
When I was waiting for a doctor, I have one now, but when I was waiting for one for 3 years here, I called this number, and it was no 811, and left my name on there. I was never contacted, and I know there's many, 100,000 people that don't have a doctor, and it's a problem. And if people don't know or don't have access to virtual care, or maybe they can't see to make a phone call, I don't know. Where does that leave them? They don't even know. They could be still on that list thinking they're still waiting, but nobody's doing anything.
So everyone on the list for the Need a Family Practice Registry, I think it was last year, were called directly by a person and asked, do you still need a do you still need a family practice, those types of things, which is why we're changing the functionality of that list, right?
I know people that are on that list that have never been contacted.
Yeah.
So,
and sometimes,
really say that.
yeah, well,
Everybody's been contacted.
yeah. So we certainly made every effort to contact everybody on that list. And then the other thing too is that sometimes, when primary care providers leave, they may have someone to come in behind them, and they take the people that are already in that practice, and they never actually take anybody, off of that list to attach them. So there's a number of different ways that we're looking to bring people in. Yeah.
Okay. Oh, we'll get you a mic. Yep, she's coming. Oh, yeah. That's okay. We'll get you a mic anyway. Look.
What is the purpose of a doctor telling somebody you only got 15 minutes to be in the office? Like, we're in a rural area. I got to go to the doctor today. I got to get my pills refilled. I got to tell them about my bad knee. And I need some eye drops for something's wrong with my eye. I don't know. That's just 3 I made up. But why would a doctor say, well, I don't have time to deal with all those things today. One thing, and then you make another appointment with my secretary. Now, I hired Mrs. Smith down the road to bring me to the hospital in the first place. I don't want to have to pay her again to bring me back 2 weeks' time. What's the purpose of the 15-minute visit? I'm sure everybody heard me.
Yeah, I heard you. Yeah. So, I'll start.
And I have told the secretary, on occasion myself, that I have more than one thing, so make sure you put me at the end of the day.
Yep. So, from the perspective of Nova Scotia Health, from the perspective of DHW, there is no 15-minute rule.
Can you say that louder?
Yes. Yes, there is no 15-minute rule.
There is no 15-minute rule.
No, there's not. But,
I
yeah.
would say there is no rule. Why did you make that up?
And, our physicians, they're doing their best to try to accommodate huge capacity, right? And sometimes the way folks try to address that capacity and address the lineup and the wait list they have to get in is to say, we can only deal with one thing today, or two things today. That should always be followed up by saying, make another appointment, come back, talk to me about these less urgent things, right? So I hope that's happening. I can speak, it wasn't too long ago. Yeah, but, yeah.
My point was, I'm in a rural area. I have to hire
Yeah, so I hope you could. I mean, I think that's communication with your physician and the team. But that's exactly what I do, is if you're finding that and you're booking an appointment with your primary care provider, say, you know, I have 2 or 3 really important issues I want to talk about, and can you accommodate that? And I think doing what you're doing, giving the heads up, is the exact right thing. There is no 15-minute rule. There's no other guidelines that we or DHW are giving physicians, but physicians are working hard, and nurse practitioners are working hard to try to get everybody seen and get everybody the care they need, and they're working under extreme demands. Maybe that's where that comes from. They care very deeply. They're trying to probably address the capacity and demand that's coming at them. What I would hope as we continue to stabilize primary care teams, like what we've done here, for example, it's convenient that I can just say here. What we've done here is we stabilize that, right? Like, we have a great team, and we've grown that team, and we've come from a very small team, which was very challenged, to a great collaborative team, which included you know, a medical resident that decided to stay here because the team here was so great and the community was so great. It was amazing. So as we continue to kind of have foot on the gas for recruitment of physicians, and also exploring how we can use other care providers to the maximal scope we can, you know, I hope some of those providers will feel less pressure because there'll be less demands. There's a bigger team around them. So I think everyone's doing their best, but I think your strategy of saying, you know, I have a few things I need to talk about, I need just a bit more time, is the right approach. So thank you.
I would maybe just add on to that around the interprofessional team in the primary care offices that are now available. So some of the concerns that people come into primary care for can be, you know, talked through with the nurse, talked through with a dietitian, pharmacist, physio, those other team members. And so a lot of practices are building up their availability of other providers so that the doctors are doing the work that only the doctors or nurse practitioners can do. And you're getting your nutrition counseling or your sore back looked at by somebody else who has that within their scope of practice. And that is designed to also free up the physician's time to do their special work and allow the other experts to provide that advice in the areas that they can.
I think my key word was rural.
I think Bethany raises next. Oh, sorry.
Somebody to take me
Yes.
into town.
Yeah.
Yeah.
And I think in a rural area, you get that a lot.
Yeah.
Mm-hmm.
We don't have taxis either.
You're right. That's right.
I think Bethany raises a very important point, though, and a lot of it is around patients and families understanding where they can and should get the care they need. So,
I think there was another lady that said something, there are also in this rural area people who don't have families and others.
yeah.
You know, just so you know that.
Yeah, no, I hear you, absolutely. What I'm saying is that, you know, traditionally, if you needed anything health-wise, you went to your doctor. You went to your family doctor, then your doctor figured out where you needed to go, right?
And you handle hundreds of patients.
Right. But people have the expectation they need to see the doctor. They need to see their family doctor, right? And in fact, we have this whole spectrum of services and providers, and very often, you don't need to see the doctor, right? You need to see the physiotherapist or the pharmacist or the NP or the chronic disease nurse. So that's what we're working hard at, is building up these teams so folks can get to where they need to get. You know, if they need to see the doctor, it's important the doctor's there. But if you need to see the dietitian or the chronic disease nurse or the physician assistant or the clinic, I mean, there's this whole community of providers. And what we need to do is make sure people get to the right place so that the physicians and the specialists can do what they do best. So, thanks.
I'd just like to put a plug in for pharmacists while I'm here. I think it's really helpful if you have an opportunity to talk to your pharmacist locally and ask them what can, you know, we're hearing a lot about that. What can you do? And so, like a urinary tract infection as an example, if it's early and it's not complicated, your pharmacist can actually assess you and treat you for that. And you don't need to go to urgent treatment. So their scope of practice, their scope of practice and their knowledge is pretty significant. And in fact, over the years, physicians have called them for advice on what type of medication to give or what will happen if I give you this and all of those things. And so, you know, we did announce a couple of days ago that there are some pharmacies that are now going to provide some primary care within their scope. So if you have a chronic disease Maybe the pharmacist can support you. Not when you're, if you have lung disease, not when you're very, very sick with your lung disease. You absolutely need to see your doctor for that. But to maintain your wellness within that chronic disease, they can help you, as an example, with your warfarin. So if you're on warfarin, they can do point of care testing. They can find out what your INR is, and they can help with the physician, to figure out what type of how much medication that you can take. And that's safe care. They're very well trained, they're knowledgeable, they're experienced, and they're able to do that. So some pharmacies do tick. If you get a tick, you find a tick, take the tick and go to the pharmacist, and the pharmacist can have a look at that, do the assessment, and decide whether or not it's a black-legged tick and whether or not you need the medication to prevent Lyme disease. So it's just really excellent, and I don't know if that covers it all, Natalie. She's a pharmacist back there. But, we want to, as an example, that's somebody in every community that can help you. And our physicians work with your physicians and your local pharmacists probably know each other very, very well, and they get to know each other's preferences and things like that, as one example. So I would have a chat with your pharmacist to see, what services they're able to provide, and, maybe how they could support you, so that you don't always feel that if you can't access your physician, you don't have any access to advice or care that you might require.
Yeah, the one thing I would just add, Minister, that's probably most important, because there is a long list of services that they can provide, is prescription renewals. So that's one of the things that we do hear often from people is, they either don't have a physician, their physician's gone to do a renewal, they can't get in to see their physician, they're going to the emergency room. And in a lot of cases, your pharmacist can actually renew those prescriptions for you. So I think, Minister, you hit it right on the head. Have that conversation with your pharmacist, talk to them about what services they're able to provide. Some of those services are available to everybody in the province with a health card. So that's really about that appropriate care, not necessarily relying, as Erin said, on seeing the physician. There are other people within that care, that circle of care for you, who could do different things that really complement each other, and they work together.
Thank you. I think we have right. Put your hand up and we'll get you the mic. Thank you.
My question is, one thing.
Can you hold them just up, if you could hold it close to your...
Okay. In speaking to what you just told us about the people utilizing the pharmacy, is that word going to get out there to the general public and older people through news or newspaper? I mean, a lot of people
don't know.
Yeah, exactly.
Yeah, we do have, this is part of the reason why we travel around to talk to folks, because it seems really hard to get our message to folks. So we are looking at things like print in mailbox, commercials, trying to see how, social media, trying to get messages out, and posters and all kinds of things. It is a shift for us as a province in terms of how care is delivered. So we are doing different types of public campaigns. What works in terms of our ability to reach seniors is very different than our ability to reach, somebody who maybe is in their 30s, right, or 20s. So there has been a lot of work. We have more to do, and also in terms of different access points where there's, how do we communicate around pop-up clinics and urgent treatment centers and all those things. So the communications is a huge piece that we're working on and refining as we go.
Mm-hmm. And just recently, in the last week and a half, I just happened to hear of or be close to two situations where an older patient was in Truro and was supposed to be moved to Tatamagouche. Her family was supposed to be let known that she was moving, and they weren't, and she ended up in Tatamagouche without their knowing. And in the transportation, they thought they were supposed to drop her off at her house. And she said, no, I need to be at the hospital in Tatamagouche. So that was worked out, and she ended up at the Tatamagouche hospital. Now another friend, she was very sick, was supposed to come home from the hospital the other day. And she didn't, it was a terrible day, the weather was awful. She didn't end up getting home until 6 o'clock, and it was supposed to happen hours earlier. She made it home safely, and I know that there'll always be glitches along the way. But would it be worthwhile, and maybe this is already happening, for someone to be navigating the movement of patients and these kinds of things so that maybe they don't happen as often?
So I can speak a little bit about that. Sorry to hear that those two things, happened. And if the transfer between the two facilities, the communication normally happens with the sending site and the receiving site confirming the transfer. So Truro telling Tatamagouche the patient's coming, and we know when the truck has left our site and when we're expecting it to arrive. And it sounds like if in that situation there might have been a process that we need to improve on. And if you want to provide more information to me, I'd be happy to follow it up so we can see what we can learn. And in terms of the transport to the patient home, so what you're describing is some of what we work on every day. We have a huddle every morning and every night in our zone where we talk together about the patient movement that needs to happen, and particularly those that rely on our EHS partners, and they sit at that table with us. So every morning, EHS knows what requests they have for transport, and they are able to tell us which ones they're able to move at the scheduled time, which ones might need to be delayed. If sometimes we have to look at the opportunity to do what we call a swap. So they're coming to Tatamagouche to drop somebody off, but they need to take somebody back to Truro. And if we could delay that, the transfer by an hour, then we can actually do a 2-patient movement with one vehicle, which optimizes the use of the paramedics and the ambulance. So we do that negotiation every day. And we have great change of communication as well. So Charbel and his team and my team, have each other's numbers as well. And if we're expecting somebody to come and pick the person up at noon and something has happened and they can't come till 3, they're calling and letting us know. And we also have the ability to call and say, we really need to move this transport up. This person more urgently needs to move, or something has changed. So we do work on that. But what I mentioned before about the C3 or the Care Coordination Center, where we have the ability to see patient bed locations and movements in hospital, EHS is also involved with that right now at the QE2. And as we scale it across the province, we expect that our ability to work with EHS with coordinating real-time movement of patients will get stronger and stronger. So we do work on it every day. We still need to keep working on it, and anything that we can learn from those two experiences that you know about, I'd be happy to hear.
Okay, yeah. Oh, we'll get you the mic. Thank you.
I find it interesting about the libraries setting up designated spots for that virtual care. Is there any plan in the future for that to be in each hospital? Like a virtual care portal?
So I would say through the emergency department, where we have the virtual emergency department, we have kiosks where people can sign up for the virtual care appointment if they need to do that. I think what you're describing is would there be a room where you could drop by at the hospital and use the room to do a virtual care primary care appointment? We haven't fully explored that yet, I'll be honest, but I think it's an idea we could take away. But what is really interesting is to try and allow that care to happen in a community location that patients and families already use for other activities. So could be a fire hall, could be a municipal office, could be a library, there could be a school, could be anything. And this partnership that we did with the library, it used library staff as the navigator and the helper. So it was actually creating more capacity for access to health without drawing on the hospital staff. So, if anybody wants to learn about the success that we've encountered in the other community, if you have a community group or, a business that thinks they might want to, try something, we'd be happy to explore it.
I feel like I'm chairing a meeting and we're doing that. Are there any other questions?
Any nominations?
Exactly, any other nominations?
I think I just want to let you know it's been great to be here. We're really happy to get out to communities and talk to people and hear directly. you know, I know, and the healthcare workers in the room, and some of you that have had to access care, we know that, you know, healthcare has been struggling for a while, and we're at this time of transformation. And the way we always did things is not really the way that we're going to always do them. So you're with us on this journey of transformation. And we will invest. We'd have to invest not only in infrastructure, buildings, but digital. So we announced one patient, one record yesterday, which is going to really help our clinicians care for us better, you know, just better communication, better access to our information, not, you know, ordering tests 2 and 3 times because we don't know what happened in Tatamagouche when you get to Truro, and Truro doesn't, you know, Halifax doesn't know what happened. So we're constantly looking for efficiencies, but not efficiencies that take away from the care or take away from our healthcare workers. That's what I would say. We're looking at ways to care for people better and to transform our healthcare system so it's more modern. So we will invest, and I just continue to ask for your patience. You know, the first little bit since we formed government is really been digging to the bottom of this well to understand what the issues were, how can we repair it, or how do we transform it? And so we have a lot of encouraging things coming up, and you'll hear us on the news announcing those and telling you about them. And the day they're announced is certainly not the day we started working on them. So I underestimated, as a healthcare worker, the dedication and the devotion and the work that happens behind the scenes. And I think that's been one of the biggest learnings for me. Totally underestimated the folks in leadership, and so that's been a humbling experience for me. So I just want to assure you, I hope you're hopeful. We are working very hard, and we certainly won't be perfect, but our intention is to make it better, and I hope that you will continue to see improvements in our healthcare over the coming months and years. So thank you for everything. It's been really a privilege to be here, and you got a good pal in Tom Taggart. When I see Tom's name on my phone, I answer it, because I know it's something that I ain't getting back to that guy. I'm going to take it right there when I need to, so it's good.
So I appreciate that, and I always get called back, and I, excuse me, appreciate the great work you're doing. I just want to say to all you folks and the folks that are around the room that are from different, you know, whether it's EHS or whatever, you know, that are part of the healthcare system, how much I appreciate that you're here tonight. You know, I should know this. There's 52 or 4 or 5 ridings in Nova Scotia. And you folks have been to 19 of them, and one of those is here. And I really, truly appreciate it, and for giving us a chance to ask questions and understand a little bit better what the challenges are in healthcare and what we're doing, what we're doing to fix them. So, truly appreciate that you're here, and I thank you very much.
Thank you.